You can start now, Ron. Okay, good afternoon, everyone, and thank you for joining us. Yeah, no? Okay, good afternoon, everyone, and thank you for joining us. Thank you for the online attendees and for the people we have here. Welcome to our fourth session of the Abu Dhabi Surgical Pathology Journal Club. So this is a monthly event that is CME accredited, hosted by Sheikh Shakhbout Medical City in partnership with Mayo Clinic. It's dedicated to surgical pathology. And every month we have one specialty with one of the brilliant keynote speakers around the world. So today our topic is about breast pathology, spindle cell lesions, and the HER2-low interpretation and implementation with Professor Gary Tsay. Dr. Tsay is a professor in the Department of Anatomical and Cellular Pathology, Prince of Wales Hospital, and the Chinese University of Hong Kong. He is the Vice President for the Asia for the International Academy of Pathology, IAP, and the President of the Hong Kong Division of the IAP. He is also currently the Regional Editors for Australasia for Histopathology, Section Editor for Diagnostic Pathology, Associate Editor for Pathology, Editorial Advisory Board member for Cancer Cytopathology, Overseas Editor for Journal of the American Society of Cytopathology. So Dr. Gary is a breast pathologist. He is well known, invited to many presentations. I would like to thank him for being here with us today. So without any further ado, Dr. Tsay.
Well, thank you, Dr. Raria, for your kind introduction and your kind invitation for me to participate in this journal club. It seems to be a very exciting experience, and I'm very looking forward to this as well. Good afternoon, everybody. Welcome to this session. And in the coming hour or so, I would like to spend most of our time on spindle cell lesions of the breast. This is a very diagnostically problematic issue, so I think I'll spend more time on this. And after that, I will conclude with a short presentation on HER2-low cancers. So I'm now sharing my screen, and here we go. Can you all see the screen? No means yes, right?
Yes, I can hear you.
Yes, yes.
Thank you. Thank you very much. Okay, so spindle cell lesions. So I understand this is more of a slide club type of activity. I've integrated several interesting cases into this presentation, but the presentation will go along with the theme of spindle cell lesions. So I think I would just go along with the presentation on the approach to diagnosing spindle cell lesions of the breast. Spindle cell lesions actually represent diagnostic pitfalls in breast diagnosis. And remember, spindle cell lesions are not the same as stromal lesions. Some carcinomas, and indeed many carcinomas, may show spindle cell morphology. In some cases, if you're lucky, you will be able to see more conventional epithelial elements. And also remember, reactive conditions may mimic spindle cell neoplasms as well. Thus, the correct diagnosis would have to base on careful consideration of clinical, radiologic information, think fully of the differential diagnosis, and the use of ancillary methods. So in the clinical history, we have to think about, could this be a recurrence, complication of irradiation? So recurrence probably will be cancer. Complication of irradiation can be sarcoma. Histology. So we need to look for epithelial elements, and then look very carefully at the spindle cells and look at the grade of the spindle cells to determine whether it is more likely to be reactive or inflammatory, benign, low grade, or high grade. Immunohistochemistry is relatively simple, so we don't have to use a lot of IHCs. We can use cytokeratins, epithelial markers, and P63. So these are the most commonly used markers for spindle cell lesions in the breast. So the diagnostic approach, remember how to categorize these. Conceptually, is very easy. You think of the tissue of origin. It could be breast specific. If it's breast specific, then it's either derived from the ductal epithelium, from the myopithelium, or from the stromal cells. If it is non-breast specific, then it's skin-associated soft tissue. So this is your usual soft tissue tumors. All right, so we'll be more interested in our discussion on the breast-specific lesions that look like spinal cell lesions. So when morphologically you're going to describe this lesion, you can determine whether this is biphasic, where there are both spinal cells and epithelial components, and usually this means it's a breast origin, or monophasic, where the lesion only contains spinal cell. In this scenario, the lesion can either be breast origin or non-breast origin. So the next thing to look at is to determine whether the lesion is low grade or high grade. This will help you to correlate with the clinical behavior. So this is a non-exhaustive list of the things that you can consider. All right, so I've divided most of the lesions into biphasic and monophasic. And if you look at the spinal cells, they can be either inflammatory or reactive. They can either look benign or look like low grade, or they can look high grade. So in the low grade benign category, when the epithelium is low grade or benign, biphasic lesions would include hamartomas, adenomyopitheliomas, PASH, fibroepithelial lesions like fibroadenomas and benign phyllodes tumor. So this will be our low grade or benign lesions that are biphasic. High grade lesions are relatively simple for biphasic lesions. There are only two. Borderline and malignant phyllodes tumor, which also fall into the fibroepithelial lesion category, and spinal cell macroplastic carcinoma, which falls into the macroplastic carcinoma category. When we look at lesions with spinal cells only, so they could look reactive or inflammatory, and this includes desmoid fibromatosis, nodular fasciitis, scars, post-op spinal cell nodules. They can be low grade, like all benign tumors, or low grade tumors like myelofibroblastoma, neurotumors, lipomatous tumors, spinal cell cells, or florid hyperplasia. Sometimes the epithelial cells will look very spindly and they would mimic spinal cells. High grade monophasic tumors would include spinal cell macroplastic carcinoma, which of course one of the macroplastic carcinomas, sarcomas, and don't forget metastasis. So with this table in mind, then you can easily approach any of the problems in breast diagnosis with spinal cells. So let's look at the first case that I prepared for you. So sorry, this picture is not taken very well, but this is a relatively oldish case, but it's really interesting. So you see this is a very cellular tumor, very busy looking, and you see patches of areas with more cohesive cells and a lot of spinal cells in the background. High magnification highlights very clearly a lot of areas of epithelial component that are cohesive. These cells are of intermediate to high nuclear grade. And if you look at the stroma, it's also composed of spinal cells that are mildly to moderately pleomorphic and again, very cellular. So if you go around some part of the tumor, there are obviously glandular or carcinomatous components. Here, this looks like in situ carcinomas, and some are like more infiltrating tubules. High magnification, apart from showing necrotic debris in the center, you can also see very complex architecture of these the tumor cells that shows glandular differentiation. Other areas, so you can see rigid lumen formation, moderately pleomorphic nuclei, a bit of necrosis, and in the background you also see areas like this. And let's look at the stroma first. The stromal cells are sort of mildly to moderately pleomorphic as well. Okay, in other areas, you see these nests of eosinophilic polygonal cells with pleomorphic nuclei. Very nice keratin pose here. And here's another area showing a cluster of these squamoid nests within spinal cell stroma. Okay, so to prove it's squamoid, so I did a P63, it was positive. This is another area showing P63. It also highlights that the spindle cells in the background are negative. AE13 again highlights the epithelial components here, and the spindle cell component was negative for AE13. Here's ER, which is negative. This is another area showing more glandular architecture, another area that this part shows more spindle cell component. And the AE13 highlights very obscure, difficult to observe small patches of epithelial cells, but otherwise the stromal cells are, or the spindle cells are essentially negative. Okay, the second case. Another very busy slide that shows spindle cell proliferation. Some of these are entrapped benign breast ducts and lobules. And if you look at the spindle cells, you can see this one is relatively lower grade, unlike the first case that we've just seen. You see normal breast tissue here. So the this is very infiltrative and engulfs the normal breast structure. And if you look at the tumor cells, the spindle cells here, they are spindled nuclei, moderate to abundant amount of cytoplasm. Some appears to be a bit clear or myxoid. When you go around the tumor in small areas, you find small patches of more cohesive epithelial component like this. There is no distinct glandular differentiation and no distinct keratinization or squamous differentiation. So this is a relatively poorly differentiated epithelial component here, together with the spindle cell components at the periphery. And at this part, we can also look at the spindle cell component, and then you can appreciate that these spindle cells are also moderately pleomorphic. High magnification, you can see these spindle cells here are somewhat pleomorphic with clear or myxoid cytoplasm. Okay, let's move on to the third case. So I'm sure you have a pretty good idea what these cases are, but let's look at this one. This one is a well-circumscribed spindle cell lesion, again, very cellular, so it's obviously a tumor, very cellular, well-delineated margins, non-infiltrative. And here you can see high magnification. Again, you can see the very smooth border, and within the tumor, you can see very pleomorphic tumor cells here. There is no suggestion of any tissue cohesion. High magnification shows areas of necrosis here. Other areas is more myxoid, cellularity is lower, but in other areas, the cellularity is really very high. If you look at the nuclear morphology, the nuclei are moderately pleomorphic to quite pleomorphic. Here you are beginning to see some new entities here. You see there's a multinucleated giant cells here, and once you start seeing this, you see more and more and more giant cells. And in the background, you see all these cells that seems to be residing in a lacuna. And another area showing very eosinophilic, homogeneous, amorphous stromal materials, and within which there are these pleomorphic spindle cells. And here you see areas of hemorrhage and a lot of these multinucleated giant cells. So this we call this osteoclast-like osteoclastic giant cells. So here you would appreciate these very myxoid, very amorphous eosinophilic myxoid stromal material here, and this is looks like osteoid, and all these cells are very pleomorphic, and they are all single cells. So I did a set B2, which is good for osteoid differentiation, osteogenic differentiation, and most of the cells were positive for set B2. ER is negative. And then we look at this area. This is a very cellular area. You see mitotic activities very easily and very pleomorphic tumor cells. But what we are now seeing is hidden at the edge here. There seems to be some little structures here. They look relatively benign. So this looks like bland epithelial components that are compressed into small slit-like spaces at the edge. And I did an AE13, and lo and behold, these show up very clearly as the epithelial, benign epithelial or ductal components. S100 also shows some of these cells are positive, and interestingly, S100, as we know, may also highlight myoepithelial cells. All right, so this ductal components is benign, is very underrepresented, overwhelmed by this stromal expansion of highly pleomorphic tumor cells showing osteoid differentiation. So what are we going to call this? The high magnification of the stromal cells. So take one more close look. Very brisk mitotic activity, very pleomorphic nuclei. AE13 is negative. S100 again shows patchy positivity, which is neither here nor there. All right, so what are we going to think about this? This is a malignant spindle cells with benign epithelial components. So this one's slightly different from the other first two cases that we saw. All right, so let's come back to this very detailed table. And this time we're going to highlight these high-grade biphasic lesions. So the most common differential diagnosis here in this category would either be a borderline or malignant phyllodes tumor or spindle cell megaloblastic carcinoma, which are biphasic. So when we are dealing with a tumor that is biphasic, what are the things that how should we approach this? So first of all, we ask ourselves, is there any epithelial component? So you look very carefully. Yes, if you see it, then it's a biphasic lesion. But then you have to remember in limited samples, for example, in a inadequately sampled tumor or in a corneal biopsy, you may not see a very rare areas of epithelial component or those that are slightly sarcomatoid. All right, so in this scenario, you may want to use IHC to help you, like CK-P63 to help you to look for epithelial components. And then you look at the grade of the spindle cells. If they are low grade, then you think of these entities like fibroadenoma, phyllodes tumor, benign, patch, hematoma, adenoma, epithelioma. But if they are high grade, then you would have to look for borderline malignant phyllodes tumor or biphasic metaplastic carcinoma. Okay, so then we are concentrating on a high-grade lesions. So these are the two entities that we need to look at: borderline malignant phyllodes tumor and biphasic megaloblastic carcinoma. All right, so this is phyllodes tumors histologic classification. This is taken from WHO 2019 book, and you can see among the diagnostic criteria for borderline and malignant phyllodes tumor. So you look at the various histologic parameters: the tumor border, stromal cellularity, which are expected to be high, stromal atypia, which is expected to be high, mitotic activity, which is expected also to be high. So for borderline, we quote 5 to 9 per 10 half-hour fields, and for malignant, we quote more than 10 per 10 half-hour fields. And then you expect some extent of stromal overgrowth in borderline and often in malignant phyllodes tumor. Malignant heterologous element may be present in malignant ones, but not present in the borderline one. So remember the osteoid that we saw in case 3 is malignant osteoid component. So that makes the lesion into a malignant phyllodes tumor because of the presence of these and the presence of benign epithelial component. Okay, so these phyllodes tumors, malignant and the borderline phyllodes tumor, show propensity to metastasize. And histology of malignant phyllodes tumor is typically markedly diffusely increased stromal cellularity, marked stromal atypia, high mitotic rate, stromal overgrowth, and permeative borders. The presence of high-grade heterologous component, like the one that we have just seen, upgrades the lesion to a malignant phyllodes tumor. The exception is if the heterologous element is a well-differentiated liposarcoma, then we would not upgrade the tumor, and we would rate the tumor using other criteria as well. So the diagnostic criteria for borderline phyllodes tumor are less well-defined. When some but not all the adverse stromal features are seen, then we call this a borderline phyllodes tumor. So the diagnosis of malignant phyllodes tumors relies on the recognition of phylloidal structure, sarcomatous component, and stromal overgrowth. Immunohistochemistry, could this be helpful? The stromal cells express occasionally P40, P63, and even cytokeratin. So this may be confused with megaloblastic carcinoma, but the expression is usually focal and more likely to be seen in the areas of subepithelial stromal condensation. How about comparing this to benign phyllodes tumor? Malignant and borderline phyllodes tumor shows higher CD117 or c-KIT, P53, EGFR, and CD10 expression. However, there's a low rate of MET12 mutation, but higher TERT promoter mutations. Mutation in cancer genes can also be seen in the malignant entities like P53, RB1, NF1, PIK3CA, P10, BRAF, and EGFR. So the differential diagnosis of malignant phyllodes tumor obviously is with sarcoma, but then we look for epithelial structures. If we find benign epithelial structures, then it is not a sarcoma. Knowing the clinical history may also be helpful. Metaplastic carcinoma to differentiate from malignant phyllodes tumor can be difficult, particularly in the scenarios when there is no H&E evidence of benign epithelial component. In this scenario, we have to look for epithelial differentiation by immunohistochemistry, which again, the epithelial differentiation can also be focal. So you have to also to remember that in malignant phyllodes tumor, the tumor cells, the spinal cells may be focally positive for P63, P40, and cytokeratin. So we need to look at the whole thing, multiple markers together. Using only one single marker and make a diagnosis is not very advisable. This is a much easier case of a phyllodes tumor, so you can see expansion of the fronds lined by a thin layer of epithelium, very cellular stroma. And if you look at the high magnification, the stromal cells shows very high cellularity. They're very crowded, and you can see very pleomorphic and bizarre mitotic figures are easily seen. All right, so this is outrageously sarcomatous, so this is the malignant phyllodes tumor. High-grade biphasic metaplastic carcinoma. So by definition, metaplastic carcinoma is histologically diverse neoplasm, characterized by the differentiation of the neoplastic epithelium into squamous and or mesenchymal-looking elements. So it says mesenchymal-looking, so it's not really mesenchymal. So the whole thing is actually epithelial. So clinically aggressive, propensity for metastasis, except the low-grade variants. Radiologically, relatively circumscribed margin, and they can be divided into, based on morphological features, matrix producing, spinal cell, squamous cell, and metaplastic carcinoma with osteoclastic giant cells. Histology, we can simply look at these and identify this as either monophasic or biphasic with or without heterologous elements. The sarcomatous component are usually spinal cells. They're usually high-grade, severe atypia, and pleomorphism, but sometimes they look like fibrosarcomas with long herringbone fascicles to short storiform fascicles. The carcinomatous component, mostly ductal, can be squamous or can be carcinoma in situ of either form. Sarcomatous components, if you're lucky, they sometimes will retain epithelial origin, so you do all your cytokeratins. Some of them will be positive. P63 is a fairly useful marker to help to identify the epithelial nature of the spindle cells. And they're usually triple negative and positive for SMA or S100. So here's an example of a high-grade biphasic metaplastic carcinoma. The lower panel shows the very bizarre spinal cells, and the upper panel shows a very high-grade epithelial component. So this is a comparison of biphasic lesions. Let's look at the morphological and the clinical features. So the clinical features for phyllodes tumor tends to be rapidly growing, risk of local recurrence and distant metastasis, but for metaplastic carcinoma, they are malignant but favor hematogeneous spread to solid organs. Radiologically, malignant phyllodes overlaps with benign phyllodes tumors. But for metaplastic carcinoma, radiologically, the appearance is variable. Some show features suggestive of benign lesions. For the histologic features, malignant phyllodes tumor, high stromal cellularity, nuclear pleomorphism, high mitotic rate, overgrowth, heterologous components. Whereas in spinal cell metaplastic carcinoma, the spinal cell shows severe atypia, and epithelial components most commonly glandular, i.e. IDC, and less commonly squamous or carcinoma in situ. So if you look at the spinal cell IHC profiles, in phyllodes tumor, they can be CD117 or CK positive, P53, P63, P40 positive, cytokeratin positive, and CD34 negative. For metaplastic carcinoma, it's pretty much the same. P63, P40, cytokeratin is positive. In some subset, SMA can be positive and S100 can be positive, and they're usually triple negative. So if you, however, I have to mention that P63, P40, and cytokeratins are usually more likely to be positive in spinal cell metaplastic carcinoma than in the stromal cells of phyllodes tumors. So we still use them, and they are still very useful. Molecular features for phyllodes tumor, the usual PIK3CA, P10, BRAF, EGFR, NF1, RB1, and P53 mutations, high stromal TET expression, and increased incidence of RA and lower MET12 mutations. So what is really useful nowadays is when we are at our wit's end, chemistry is not very helpful. What shall we do? Then we can look at the genetic changes of these lesions and then try to decide whether it's actually a phyllodes tumor or metaplastic carcinoma, particularly in the setting of a core needle biopsy. So in phyllodes tumor, in a descending order, the most common changes are MET12 mutation, TET promoter mutation, RA, and SETD2. Whereas for metaplastic carcinoma, it follows all high-grade breast carcinomas. So it's P53, PIK3CA, ARID1A, and etc. So you see the top genes that shows mutations are different. So with this, so you can make a panel out of the 4 commonest genes and then look at them. And this will be very helpful to help you with differentiating between malignant phyllodes tumor and malignant high-grade metaplastic carcinoma. Okay, so next we move on to the low-grade cancers. The low-grade biphasic lesions. So these are actually not cancers. So the common lesions include fibroadenomas, benign phyllodes tumor, PASH, hematoma, and adenomyoepithelioma. So fibroadenoma belongs to fibroepithelial lesions, so we are all aware of these entities. If you look at the WHO, both fibroadenoma is put practically next to benign phyllodes tumor, indicating that these benign fibroepithelial lesions are part of the same spectrum, and their appearance is also can be very similar. So fibroadenoma is most common. Palpable mass do not recur. Rarely cyclosporine usage would stimulate bilateral multiple fibroadenomas. The histology we are all very familiar with. The epithelium shows intracanalicular and pericanalicular pattern, whereas the stromal components usually uniform, of low cellularity, and lacks atypia. Secondary changes are common, include usual hyperplasia or even DCIS, LCIS, and ADH, etc. Squamous microplasia, PASH, and stromal smooth muscle microplasia has also been reported. If you have a fibroadenoma, if you have a typical foci inside the fibroadenoma but not extending outside, then the overall prognosis is the same as a normal fibroadenoma. We don't usually do IHCs for fibroadenomas, but if you really want to, the stromal cells can be positive for CD34 and BCL2. And if you really want to do molecular studies on fibroadenoma, you would find hotspot mutations of MET12 at exon 2 in about half of the fibroadenomas in amino acid 44. So here's a nice example of a fibroadenoma. So you can see expanded myxoid specialized breast stroma with intra and pericanalicular pattern of the ductal epithelium. So there are other entities. Cellular fibroadenoma basically is mostly pericanalicular growth pattern, increased cellularity. The prognosis is same as normal fibroadenoma. Complex fibroadenomas with one or more of the following features: cysts, more than 3 millimeters, sclerosing adenosis, epithelial calcification, and or papillary apocrine microplasia. David Page published a series many years ago, and it's associated with a slightly increased risk of cancer, but the risk is really very slight. It's not even that of a typical hyperplasia type of risk. So it's present in 3 to 4% of benign breast biopsies and 16 to 23% of all fibroadenomas. Okay, here's an example of a fibroadenoma with a superimposed epithelial hyperplasia. So you can see these are the fronts of the fibroadenoma, and you see very nice epithelial proliferation here. Monotonous, rounded nuclei, minimal amount of cytoplasm, rigid architecture. So this is a focus of DCIS involving a fibroadenoma. Okay, phyllodes tumor. Overall is rare compared to fibroadenoma, and it constitutes less than 3% of all fibroepithelial lesions. And among all phyllodes tumors, most of the phyllodes tumors are benign. 2/3 of them are benign. When they're benign, they run a benign clinical course and older age of the patients compared to fibroadenomas. So histologically, the variable features we've gone over before: the stromal cellularity, phylloidal pattern, stromal atypia, which is usually mild, low mitotic count, well-defined borders, and absence of stromal overgrowth. If you want to do immunohistochemistry, actually, for most cases, the diagnosis does not require IHC. You can stain the stromal cells for CD34, BCL2. They should be P40 and P63 negative. Rarely, beta-catenin, P63, and cytokeratin will be positive, but these are really rare, focal, and weak, and only occurs in malignant examples. In benign Pathology tumors is really very rare. Similar rate of MET12 hotspot mutation as in fibroadenoma, and higher than malignant and borderline Pathology tumor. High rate of third promoter mutation, FLIN mutation, and SETD2 than fibroadenomas. So there's some slight difference, but on the whole, the molecular scenario is very similar to fibroadenoma. So how do we differentiate Pathology tumor against fibroadenoma in a histologic slide? Pathology tumor possess uniformly more cellular stroma, increased stromal condensation next to the epithelium, and phyloidal patterns. In biopsies, the stromal features include higher cellularity and pleomorphism in Pathology tumor. Other features in biopsies include fragmentation because of the phyloidal patterns, more prominence of intracanalicular patterns, and the presence of multinucleated stromal giant cells. But all these are not very specific. So these are a soft sign that you have look at all of them and think and add them together and think of a reasonable interpretation. So Pathology tumors against cellular fibroadenoma, this differentiation may be difficult. However, this may not be significant because they have similar clinical outcomes in terms of reported recurrences. In this scenario, in a biopsy setting, you may want to report benign fibroepithelial lesion to avoid having to differentiate between these two entities. Okay, so here's an example of something that looks like a fibroadenoma with expansion of the stroma, and you see the ductal components forming slit-like spaces, both intracanalicular pattern and pericanalicular patterns. But in this area, look very carefully, you seem to see expansion of the stroma. Let's concentrate on the other areas first, and you see the ductal epithelium, and if you look at the stroma, they are a bit more cellular than you would expect than fibroadenoma. And you actually see mitotic counts, not that difficult to find mitosis in the stromal cells. So you're beginning to think, maybe this is not a fibroadenoma. Indeed, it is a benign Pathology tumor. All right, so hematoma is discrete breast mass, variable consistency is benign. We are familiar with the histology is nodule with variable adipose tissue, lobules, ducts, fibrous tissue. To me, the most important diagnostic criteria would be interlobular fibrosis, encapsulated fat, and sometimes the presence of PASH-like changes in the stroma. In reported cases, coexisting in situ invasive cancers can be found. And the stromal cells resembles normal breast stroma. They may express hormone receptor and smooth muscle markers. So here's an hematoma, relatively well circumscribed in this particular case, and you can see it's well delineated from the adjacent breast tissue because for this case, the hematoma is more fibrous than fatty. So you can see this is an enlarged ductal lobular units, but you can see fibrous tissue with between the lobules. So it looks like an atrophic lobule, and this is what is characteristic of hematomas. Apocrine cyst and expansion of the stroma and normal cyst. So that's what you see in hematoma. Adenomyoepithelioma, predominantly occurring in elderly female with a peak age of more than 60 years old. This clinically benign presents as a solitary palpable mass. Mammographically, it's a solid mass, where in histology, you will see bland ductal epithelial cells within hypoplastic myoepithelial cells. The myoepithelial cells can be basaloid, can be plasmacytoid, can be spindled, and they can have clear or eosinophilic cytoplasm. Rarely, aggressive adenomyoepitheliomas has been reported, and these cases show malignant histologic features. The histologic features are both can either occur in the epithelial components or in the myoepithelial component. It doesn't matter in whatever component, we still call this the atypical or malignant adenomyoepithelioma. So rarely you may also see heterologous components like chondrosarcoma or osteosarcoma as well. So if you want to do immunohistochemistry, myoepithelial markers like SMA, caponin, S100, basal markers like P63 would be positive for the myoepithelial cells, and cytokeratin would highlight up the epithelial components. PESH is a benign lesion showing stromal myofibroblasts. The nodular PESH may present as a palpable mass detected by imaging. So histology, complex interanastomosing channels resembling vascular spaces, but they're in fact lined by myoepithelial cells. There may be fascicular areas with obliteration of the pseudoangiomatous spaces. Markers, CD34, BCL1, SMA, Vimentin, ER and PR positive. So in fact, PR positivity is observed more commonly than ER positivity. The spinal cells may also be positive for SMA and Vimentin. And more importantly, endothelial markers like CD31, ERG, and D240, cytokeratins, and S100 are all negative. So we are now comparing the biphasic lesions with planned spinal cells. So we have fibroadenoma, phyllodes tumor, PESH, hematoma, and adenoma epitheliomas. So you can see basically clinical features, they're all pretty much similar, palpable masses or discrete mass, etc. Radiological features not very differentiating. How about the histological features? So we've just gone over the histology. We know the histology of these entities. And IHC profiles, you can see CD34 is not useful. BCL2 may be useful because it's maybe positive in some, but not other lesions. But on the whole, you can see there are no easy way to tell. But I think based on the histology, and if you look very carefully, you will be able to tell, to differentiate between all these entities. So if you look at the molecular features, again, this highlights the similarity between fibroadenoma and the benign phyllodes tumor. So you see MET12, RA somatic mutations, and a bit more in benign phyllodes tumor compared to fibroadenomas. And this includes ZD2, KMT2D, and BCOR. All the others are not, there are not many genetic changes. Okay, let's move on to the next case. Sorry, again, it's another blurry picture of spinal cells. So you can see these are line fascicles and bundles of spinal cells that are here, and you can see the spinal cells are very, very mildly pleomorphic. No ductal, there's no any organization, no architectural pattern, no benign epithelial components. And if you look at high magnification or intermediate magnification, you can see these spinal cells are relatively bland looking, and they seem to be going in fascicles in one direction. And high magnification, again, showing relatively bland spinal cells, elongated eosinophilic cytoplasm. And you know the answer. Beta-catenin shows very nice nuclear positivity. Okay, so this is the case of breast myofibromatosis. Oh, sorry, I mean the breast fibromatosis. Okay, so we are now moving on to the monophasic lesions. So when we are dealing with the monophasic lesion, the first question again that we ask ourselves is there any epithelial component? You look very carefully, very carefully, sample adequately. No, we don't see. So it's monophasic lesion. We have to take caution either to sample adequately to make sure there is really no. And on the other hand, you should also be very cautious when you see entrapment of epithelial structures at the edge of the lesion and not in the center of the lesion. And in this case, this is entrapped epithelial lesion, and don't think this is a biphasic lesion. And then you look at the spinal cells, look at the determinate grade and the nature of the spinal cells. If the spinal cells look like they are inflammatory or reactive, then you think of scar, reactive spinal cell nodule, nodular fasciitis, or desmoid fibromatosis. If the spinal cell looks malignant but low grade, or looks benign and low grade, then you may think of myofibroblastoma, fibromatosis like metaplastic carcinoma, and other rare mesenchymal tumors. If they're high grade, then again, there are only three entities that you need to think about: metaplastic carcinoma, sarcomas, and metastasis. Don't forget metastasis. Okay, so these are the entities that I've just mentioned. So in the inflammatory and reactive category, there are fibrous scars and reactive spinal cell nodules. So these occurs within a month following the procedures. Any procedures can trigger the formation of this reactive spinal cell nodule. Vague nodular proliferation of spinal cells, mild to moderate degree of nuclear pleomorphism, prominent nucleoli. Sometimes you see mitotic activity. The accurate diagnosis hinges on the history of trauma, procedure, or microscopic clues. Background: a lot of inflammatory cells, foreign body giant cells, homihistiocytes, hemosiderin-laden macrophages and granulation tissue. It's basically an exuberant tissue response. And if you want to do immunohistochemistry, I can tell you AE13 will be negative, so you basically stain for myofibroblasts like SMA, MSA, and vimentin. So here's an example, and you just hope that you don't get this in frozen section because this can be very alarming and very, very difficult to diagnose. So here's a spinal cell lesion here that shows very haphazardly arranged spinal cells that seems very active, mildly to moderately pleomorphic, and high magnification. If this is a frozen section slide, actually, I actually had this in a frozen section. So you can see the the stroma is a bit edematous, but otherwise the spinal cells are very moderately pleomorphic, and it seems to be quite alarming. And there are also areas where they were grouped together, and then you can see really hyperchromatic nuclei that are pleomorphic. High magnifications, you see mitotic activities here as well. So this is really alarming and can really be misleading. Okay, the next category, the next entity is nodular fasciitis. It's a reactive proliferation triggered by local trauma or injury. So it's rapidly growing painless mass and very often spontaneous resolution. So radiology is irregular encapsulated spiculated mass. May look suspicious for cancer. So histology, we're familiar with the histology of nodular fasciitis, chronic inflammatory cells, small capillaries, extravasated red cells, myxoid materials, and spinal cells in bundles and fascicles. And nodular fasciitis has very well established USP6 gene rearrangement that we can look for in hinging the diagnosis. Desmoid fibrosis. We've just looked at one case just now. So it's a locally infiltrative tumor without metastatic potential. It's mostly sporadic, but some in post-op patients are adjacent to implants. The subset occurs in FAP patients with germline APC gene inactivation. And so sometimes when the this APC gene mutations may be seen within these cases. So radiologically, they are suspicious. Spiculated borders, tethering of the Cooper's ligament, involvement of intercostal or pectoralis muscles in a patient. So histology, bland nuclear features, minimum pleomorphism, rare mitosis. The fibroblasts and myofibroblasts are arranged in long sweeping fascicles, dense keloid-like collagen, inflammatory cells, and they may invade muscle or sometimes perineural invasion as well. So for the markers, a whole bunch of them is very commonly done, but not very useful. SMA vimentin positive, S100 CD31, CD34, cytokeratins, and EMA negative. Mutations APC beta-catenin pathway in FAP-associated cases occur in a minority of cases. But the most cases would show evidence of beta-catenin pathway activation, and we usually will be able to find CTNNB1 gene mutation. So this is one of the telltale histologic or molecular tests that we do to confirm a diagnosis of fibromatosis. Okay, low-grade lesions, myofibroblastoma, fibromatosis like metaplastic carcinoma, and other rare mesenchymal tumors. Myofibroblastoma occurs in postmenopausal women and men without sex predilection, slow-growing, painless, non-tender mass. Radiologically is well circumscribed, and histology short fascicles of myofibroblasts with bland nuclei in distinct pale cytoplasms and in distinct borders. The background shows thick ropey collagen bundles. There are other variants, including epithelial variants, invasive variants, and symplastic variants. More importantly, the diagnosis hinges on the immunohistochemistry, CD34, ER, and AR. Other markers like SMA, BCL2, and CD99 are variable. So 13q14 deletion resulting in loss of RB can be done and occurs in 70 to 80%, or actually 90% of the cases, and can be done by FISH. Fibromatosis like metaplastic carcinoma is an indolent subtype of metaplastic carcinoma that looks like fibromatosis. Spinal cells with low to moderate cellularity, infiltrating edges, and trapping adjacent breast lobules, and most of the lesions contain bland spinal cells, but some only show mild atypia or nucleoli. So for these type of cases, they are very likely locally recurring, but they do not metastasize. So in general, the prognosis is very good. Mortality is is very low. So how do we diagnose this when we are thinking of this diagnosis? Of course, it's a metaplastic carcinoma, so we can do cytokeratins. So reactivity to cytokeratins, just do all the cytokeratins that you have, and P63. They will be negative for SMA, ER, PLHER2, and Ki67 will be low. And unlike extra-abdominal fibromatosis, there's no diffuse nuclear beta-catenin expression. So this is metaplastic carcinoma, no beta-catenin nuclear expression, but there is cytokeratin expression. Okay, case 5. This is a big core of a breast tumor, very pleomorphic tumor cells, bizarre mitosis, highly pleomorphic nuclei, also very brisk mitotic activity as well. As you can see here, the nuclei have prominent multiple nucleoli, so on and so forth. There's no cohesion, no glandular arrangement, no squamous arrangement. All right, and we do not see heterologous element. And here you can see again another area showing pretty much the same bizarre spinal cell nuclei here. High magnification shows pretty much the same thing. So you've seen enough. Now we did a P63, it is positive. So would you consider this strong positive or what? This is actually for identification of carcinomas using P63, you do not need a lot of positivity. To me, 2%, 3% positivity is good enough. So in this particular case, to me, it's a very good, strong positivity, very nice, clean nuclear staining. High magnification again shows the staining occurs in actually the tumor cells. So all these bizarre cells are P63 positive. And I was lucky in this particular case because AE13 was also negative positive in some of these spinal cells. So again, similar to P63, you only need to have a few AE13 cells that a few cells that are AE13 positive, then it would confirms the diagnosis of epithelial in origin. All right, so this highlights the pleomorphism to nuclei showing AE13 staining. So this case is a monophasic spinal cell metaplastic carcinoma. All right, so in a high-grade category, so it's monophasic spinal cell metaplastic carcinoma, sarcomas, and metastasis. So monophasic spinal cell metaplastic carcinoma is particularly aggressive among metaplastic carcinomas. Mostly highly pleomorphic spinal cells, no phenotypically obvious carcinomatous component, lack of cellular cohesion, lack of glands or tubules or squamous differentiation. The spinal cell usually possesses subtle epithelial features, but may be very focal. Like in the case we've just seen, there are only a few cells showing AE13 positivity or P63 positivity, but that is enough for us to make the diagnosis. So the markers, we need to pick up areas that showing focal areas of cellular adhesion or the epithelial component. So focal to diffuse reactivity to high molecular weight cytokeratin, P63, and other basal epithelial markers. So a diagnosis can be rendered based on the evidence of epithelial differentiation. So if you have any markers that's positive, even focally or weakly, then you can make a diagnosis of this, calling this a metaplastic carcinoma. So this is a very elegant study that was reported by a good friend from Nottingham, Professor Emaraka, last year. So he looked at a whole bunch of cytokeratin negative metaplastic carcinoma. So out of many cases, 140 cases of metaplastic carcinoma that he looked at, 22 were negative for cytokeratin. He tested for at least 3 cytokeratin markers, so they were all negative. So let's look at this table here. So this indicates what happens to cases, but let's look at here. Of the 22 cases, 12 cases were diagnosed with metaplastic carcinoma based on associated carcinomatous elements, meaning that he looked more carefully or took more samples, then found in other areas carcinomatous components like ductal IDC or squamous cell carcinoma or carcinoma in situ. Okay, for the remaining 10 cases, 2 cases show scanty D-size foci upon further sampling. All right, so again, you need to sample very carefully to look for the epithelial components. So 14 cases down, 8 more cases. Of these 8 more cases, there was no evidence of DCIS, conventional breast cancer, cytokeratin, and common breast marker expressions were all negative. So in 5 cases, there was a history of breast cancer with an indirect evidence of carcinomatous nature demonstrated by comparison with previous lesions. So it's these 5 cases were apparently recurrences. So the patient had the previous history of megaloblastic carcinoma, so the case recurred. So despite the negativity for breast markers or negativity for cytokeratins, the diagnosis was made. 3 cases was based on a balance of probability and exclusion of other entities. So 3 cases were based on exclusion. So you can see in this particular series, Professor Raka did not actually call any of these cases primary sarcoma. And he called all these cases megaloblastic carcinomas, even though some there was no solid evidence except probability and exclusion of other entities. All right, so this seems to be the prevailing thought for most practitioners in breast pathology. So we think megaloblastic carcinoma, spinal cell carcinoma is far more common than primary sarcomas of the breast. So this is an example, so you can see this is just very bizarre. If I would just do all the cytokeratins in my lab at this and try to make this positive and call this a megaloblastic carcinoma. Sarcoma of the breast is extremely rare. Overall, show poor prognosis and low overall survival. They may present as palpable breast lump, radiologically detected breast mass. They metastasize to the visceral organs and not to lymph nodes. So it's very heterogeneous. Common ones include angiosarcoma. Others include leiomyosarcoma, osteosarcoma, chondrosarcoma, liposarcoma, and myofibroblastic sarcomas. So here's an angiosarcoma. You can identify it very easily. Very bizarre or pleomorphic or malignant endothelial cells, hemorrhage in the background, and anastomosing channels. This is a post-irradiation sarcoma. So you can see very bizarre spinal cells, irregularly arranged, highly pleomorphic. Higher magnification shows brisk mitotic activities here and high degree of pleomorphism. Metastases to the breast are rare and constitute 2.3 to 2.7% of malignant breast tumors. So what are the common primaries? This includes cutaneous melanoma, pulmonary and ovarian carcinomas are most frequent. The other potential mixed or potential mimics would be sarcomatoid squamous cell carcinoma or spinal cell melanomas are potential imitators of malignant spinal cell lesions. So we need the relevant clinical history, whether the patient had previous lesions or previous diseases. Periductal distribution of the tumor cells and absence of carcinoma in situ would be a hint to metastasis. Ancillary IHC markers. So we do breast markers. We know like GFP15, mammoglobin, GATA3 is useful to determine breast origin. However, you have to remember that GATA3 is also expressed in urothelial cancers. And all these markers are more sensitive than ER, are more sensitive at detecting ER positive than triple negative breast cancers. So if you have a case that that you cannot tell and they are all these markers are negative, it still can be a primary breast cancer, probably a triple negative breast cancer, as compared to a metastatic carcinoma. So you need to think very carefully. And also the another marker that's very useful for triple negative breast cancer is SOX10. Which is a neuro and melanoma marker, but SOX10 has been shown to be very sensitive to triple negative breast cancers. So you can consider using SOX10 as well in this scenario. So multiple breast markers are suggested, and I also suggest that you add SOX10. All right, so in our final approach to spinal cell lesions, we have to look at firstly whether this is biphasic or monophasic. If it's biphasic, you have to make sure it's not entrapped epithelial component. With this in mind, then you can look at whether the spinal cells are high grade or low grade. If it's low grade, biphasic with normal epithelium, then, I mean, this is normal benign epithelium, then you will think of fibroadenomas. And if the spinal cells are low grade, then you think of benign Phyllodes tumor. However, if the epithelium is high grade, then you would be thinking, if the spinal cells are high grade and if the epithelium is benign, then you think of malignant Phyllodes tumor. And then here you look for fronded epithelial cleft, MET12 mutants or MET12 mutation, which is lower, and the other things is RA and TERT promoter mutations. If the spinal cells are high grade and the epithelial component is malignant, then you will be thinking of biphasic metaplastic carcinoma, and you confirm this by diffuse epithelial differentiation, CK and P63 positive. If the tumor is monophasic, you have to extensively sample the tumor to make sure there's no epithelial differentiation in the entire lesion. Then you look for the spinal cells whether they're low grade or high grade. If it's low grade, then if they look like reactive, then you think of the reactive lesions like nodular fasciitis or scar. So you need to check the history very carefully. If they have fascicular appearance, and then they can either be fibromatosis or fibromatosis like spinal cell carcinoma. So you know what to do. You look for cytokeratins, you look for CD34, you look for a nuclear staining for beta-catenin, and vice versa. All right, so if the spinal cells are high grade, then you will be looking for whether it's a sarcoma or whether it's a monophasic metaplastic carcinoma. So without further staining, then by chance, you should place your bet on this one, monophasic metaplastic carcinoma, because it's far more common than real sarcoma. But you need a history to know whether this is potentially a recurrence. And I think this will be eventually an exercise in exclusion based on immunohistochemistry, or you can do confirmatory tests using molecular techniques. So most of the materials that I presented here has been published in this review article that was just out recently. Thank you very much for your attention.
Thank you very much. Thank you very much. You hear me? Thank
Yes.
you, Sir Gary. Yeah. Do we have any questions here for the online audience? You can write any question you want online. We still have one more short topic. Dr. Gary, do you have any question here among our audience? Anything? I like the last slide. Really, it summarizes the approach to monophasic and the biphasic lesions. So I don't see any questions. Do you have any questions online, Ron? There is one more chat over here. You see? Yeah, mostly. Thank you. Okay, so we don't have any questions, so we can proceed to HER2 low.
Okay. Let me. Okay, I can see my screen.
Yes.
Okay, so this will be a much shorter presentation on HER2 low breast cancers. So it's I would approach this from a pathologist perspective. This is because this is a HER2 low issue is basically a clinical and oncological issue. So so I think as a pathologist we need to know this story quite well. Otherwise, our oncologists will be asking us a lot of questions that we will find it very hard to answer. Okay, so why is that so important? Because traditionally, HER2 has been with us for a long time, for 20 years, but we have been taught to look at HER2 by either IHC or FISH or SISH, and we have been taught to categorize the results in a binary manner, i.e. either negative or positive. Why? Because 20 years ago or 10 years ago, HER2 positive cases are eligible for trastuzumab treatment, and equivocal group was abolished in the latest guideline because we don't want equivocal. We only want positive and negative. Positive, then they go for trastuzumab. Negative, no trastuzumab. So the story begins to unfold. We must start at 2007 to 2013 when the ESCO published guidelines on teaching pathologists how to score HER2. So in 2018, which is the latest guideline, you can see the trend was still towards classifying HER2 into positive and negative. So in the 2018 guideline, there were a few changes. One of the changes included they updated the definition of IHC2+. They highlighted the repeat testing on excision specimen, and also for the equivocal subgroup that has been around for a long time, they abolished the equivocal group for ISH and only retained the equivocal for IHC. So the IHC equivocal will go for ISH. Eventually, the equivocal will be gone after 2018 guideline with the IHC and ISH. So let's look at something simpler, considering consideration for retesting of HER2 in the 2018 guideline. So if the biopsy is negative, you need to retest in excision if the tumor is grade 3. If the amount of invasive tumor in the core biopsy is small, if the resection specimen contains high-grade carcinoma that is morphologically distinct from core needle biopsy, and if there is doubt about the handling of the core needle biopsy, so you can repeat if you have all these questions or issues with the core biopsy. And if you look at the HER2 status assessment, if you look at my circle here, this is 2013, this is 2018, and this boxes represents the IHC interpretation. So you can see in 2018, the interpretation for IHC equivocal is simplified from 2 criteria to 1. It's more than 10% invasive tumor cells showing weak to moderate complete. So it needs to complete, but weak to moderate, then it becomes 2+. Then you need to do an ISH for this case. However, the ISH interpretation is a different story. So they have put the ISH categories into 5 combinations basing on a HER2 CEP17 ratio. So we know if the ratio is more than 2, then it's positive. And if the HER2 signal amplification is more than 4 per cell, then we also consider this positive. So it's double positive is positive and double negative is negative. But there are a whole bunch of other things that's intermediate. And previously, some were considered positive, some were considered equivocal. But now they were all considered either positive and negative. But look at this, group 2 was positive and now negative, and group 3 was positive and now positive. Group 4 was equivocal and now negative. So you can see in 2018, the prevailing trend of thinking is to classify HER2 into either positive or negative. So everything is made into a binary manner, either positive or negative, and there's no equivocal anymore. So the groups 2, 3, and 4 accounts for a small proportion of all the breast cancers. Overall, it's different series or different databases. You can see approximately 5% of the cases will fall into groups 2 to 4 category. So nowadays, basing on these 2018 recommendations, this is how we do it. So we do that. We started, let's say we started off with an ISH. So we have tumors that are group 1, group 2, group 3, group 4, and group 5. If they're group 1, then they're positive, no further tests needed. If they're group 5, then they are negative, no further tests needed. If they're groups 2, 3, and 4, then we do an IHC on the same block. If the IHC is 3+, then any of these are considered positive and end of story. If IHC is 0 to 1+, then they are all considered negative and end of story. If the IHC was also equivocal, 2+, what shall we do? Then we don't do anything more. We recount the ISH, and if it's continued to be group 2 or group 4, then they are negative, and group 3, they are positive. So group 1 and 3 positive, groups 2, 4, and 5 negative. That seems very straightforward, and that seems very easy. And then come along the current concept of 3-tiered categorization of HER2. Now we are moving away from HER2 negative and HER2 positive to HER2 negative, HER2 low, and HER2 positive. So we're now adding an intermediate category in between. So what are HER2 low cancers? So they are IHC score 1 to 2+ without amplifications. So they have ISH negative, but IHC 1+ or 2+. So they accounted for 50 to 60% of all breast cancers. What are the potential mechanisms leading to HER2 upregulation? So it can be upregulated by crosstalk with HER2 pathway instead of the gene amplification. And they can also be upregulated by the NF-kappa B mediated upregulation pathway. This occurs usually after chemotherapy or radiotherapy, or stimuli from tumor microenvironments like fibrosis or inflammation. So what is the clinical relevance of HER2 low? Why are we all of a sudden interested in HER2 low? It's because it's clinical relevance for this trastuzumab deruxtecan or TDXD treatment. So before we look at TDXD in greater details, let's look at how do we make a diagnosis of HER2 low. All right, so this is our usual testing protocol. HER2 test by IHC. If they are 3+, then it's positive. If it's 2+, then we do FISH. FISH positive, then it becomes positive. FISH negative, then it falls into HER2 low category. If it is incomplete membrane staining, so it's IHC 1+, then it's automatically HER2 low, even though it's HER2 not considered positive, and there's no ISH. If it's HER2 0, then it's HER2 negative. All right, so we have a group of HER2 low cancers here that's been around for a long time, but now we need to deal with them very carefully and very diligently and reproducibly. And if you look at this pie chart, you can see that HER2 low is actually in a very important category because it accounts for more than 50. So it's like 50 to 60% of all breast cancers. So how do HER2 low breast cancers compare to other breast cancers? So HER2 low breast cancers are, as a large group, are heterogeneous. Among the hormone receptor positive HER2 low breast cancers, which account for 2/3 of the HER2 low breast cancers, the HER2 low cancers express more higher ERBB2 and luminol-related genes compared to the HER2 negative cancers. So they are more likely expressing HER2 activation pathways. However, in the triple negative breast cancers that are HER2 low, so it sounds very contradictory, but this is like triple negative is like HER2 negative is triple negative, HER2 non-positive is triple negative. So some of these triple negative breast cancer cases are actually HER2 low and not HER2 0. All right, so in this scenario, the HER2 low and HER2 0 cases, there is no difference in expression of ERBB2 genes and luminol-related genes. So it seems there is that the HER2 low category is really a heterogeneous group and shared some similarity, but some differences with HER2 0 categories. So for the HER2 low breast cancers, in hormone receptor breast cancers, when they're basal-like breast cancers, they're more likely to be HER2 0 than HER2 low. If you compare HER2 low with HER2 0 cancers, HER2 low cancers tend to be lower grade, ER positive, and show lower Ki67 expression. So as a result, they tend to show better outcome. So you can see show better survival than HER2 0 cancers. The hazard ratio is quite good here, 0.56 and 0.65. And this outcome depends on hormone receptor expression as well. So by HER2 low by itself does not appear to be a biological distinct entity. So it seems to be a mixture of different things. So we need to spend more time learning about this HER2 low category. All right, now we come to the TDXD, the drug. When we are targeting HER2 in treatment of breast cancers, there are 4 ways that we can target the HER2. So we can use monoclonal antibodies. Trastuzumab is a typical example, like Herceptin. So it's basically a monoclonal antibody that binds to the HER2 receptor. So it blocks the binding of HER2. The other category includes antibody drug conjugates, or ADC. So this basically uses the same antibody as like a trastuzumab, and the antibody is linked to a linker, which in turn is linked to anti-tumoral drugs. And sometimes this is a more effective way of killing or of treatment because the linker can have many arms and link to multiple, more than one anti-tumor agents. So if that is the case, then it gives a very high efficacy in treating the cancers. There are other mechanisms like bispecific antibodies in which the antibody binds to 2 entities, 2 receptors, or an inflammatory cells or the HER2 receptor at the same time, and also vaccines. But we are concentrating on this antibody drug conjugates because the TDXD is an antibody drug conjugate. So TDXD is an ADC or antibody drug conjugate with a novel potent topoisomerase 1 inhibitor. So all right, so this is a typical or prototypic ADC. So this is a very important, a very efficient ADC because it has very high payload per DXD molecule or per antibody. The antibody can link to 8 molecules of the drug. So as a result, this is, I would say, 8 times more potent than a Herceptin molecule. So it shows efficacies and HER2 specificity in HER2 low expressing animal models. So it has been shown that this TDXD is actually really binding to HER2 receptors. So let's look at this outcome in these experiments. So in this experiment, the authors look at 4 different cell lines with no HER2 0, HER2 1 plus, HER2 2 plus, and HER2 3 plus. The red lines here represents the, so here represents tumor volume, and red lines represents the tumors that were given TDXD. So you can see here in this KPL4 cell line, which is HER2 positive cell line, so you can see TDXD as well as other drugs all decrease the tumor volume, and when there's a placebo, the tumor volume increased. So all 3 were effective in HER2 3 plus cases. Now in HER2 2 plus cases, you can see that the TDXD is most effective, resulting in the lowest increase in tumor volume. And in the most important or most interesting result is this one. In this CAPN1 cell line, this is a HER2 1 plus cell line. So you can see here when you give all these drugs, TDXD remains very effective and keep the effective tumor volume very low, whereas other agents that were used in this experiment failed to lower the tumor volume, and the tumor volumes continue to go up. All right, so it highlights the fact that TDXD is very effective in high HER2 setting, as well as in low HER2 setting. So that's why people are very excited about this. Okay, when we talk about TDXD, there are 2 clinical trials that we need to know about. These 2 has just released the results earlier this year. So this first one is Destiny Breast 04 trial. So in this particular trial, this is a likely pretreated HER2 low breast cancer patients. Pretreated HER2 low breast cancer patients. All right, so let's look at this area, only this area. So this is response to treatment. So this is all patients. So this is TDXD, and this is physician's choice of chemotherapy. So whatever the physician thought is the best for the patient was given to the patient. So you can see here, 52% showed responses with TDXD treatment, whereas only 16% showed responses to physician's choice of chemotherapy. So the TDXD was much more effective in dealing with patients that have HER2 low breast cancers compared to physician's choice. All right, so this is one very exciting trial. So that's the trial that brings HER2 low and the TDXD onto the scene of our oncology treatment for breast cancer patients. The other trial is the DAISY trial. In this particular trial, they are looking at slightly different patient population. The patient population is heavily treated advanced breast cancer patients. Again, so they've divided the patient cohorts into 3. Cohort 1 is a HER2 positive cancers patient. Cohort 2 is HER2 low expressing cancer patients, and cohort 3 is HER2 negative patients. So you can see here, the best overall response occurred in HER2 positive cancers, 70%, HER2 low 33%, and HER2 negative 30%. So you can see here, HER2 low also responds in some part to TDXD, but not as good as HER2 positive, but it's slightly better than HER2 negative, but slightly better, but almost similar. So even the progression-free survival in terms of months is also very similar. So you can see HER2 low when given TDXD was very similar to HER2 negative, more similar to HER2 negative than HER2 positive. So with this in mind, we know TDXD is very effective against HER2 low cancers. However, the problem now is with us pathologists. We have been taught to look at HER2 usually to diagnose HER2 overexpression and amplification. So the definition of HER2 low differed from HER2 positive, which is linked to a definite genomic aberration and is stable in time. So HER2 positive can be proven by an amplification, but HER2 low cannot be proven because it's an IHC artifact. So there are issues for HER2 low assessment. Firstly, there's lack of reference standard for validation. Secondly, there's tissue heterogeneity. So there are temporal heterogeneity and spatial heterogeneity. Temporal heterogeneity meaning the change of HER2 expression over time, and spatial heterogeneity means the change of the HER2 expression in different parts of the tumor. Again, there's also high inter-observer variability, particularly in the IHC 0 and 1+ areas. And the antibodies that we use are not also standardized, and different antibodies give different results in staining. All right, temporal heterogeneity of HER2 expression. So HER2 expression may change over time. So, in the DAISY trial, you remember HER2 0 and HER2 low show very similar response to T-DXd. So we're not sure why. So is there a cutoff? In the Destiny trial, in the Destiny Breast 04 trial, it seems that the HER2 T-DXd was more effective in HER2 low breast cancers. However, in this case, both fresh and archival biopsies were used. So we're not sure whether this would affect the sensitivity of the test or results to the T-DXd. And also HER2 low expression can change over the evolution of the disease. So it's known that the HER2, there's a significant discordant rates between primary and recurrent tumors, and this discordance ranged from 38 to 44%. So this is really significant. 40% of the tumors, when they recur, they have a different HER2 scoring. Mostly they're due to switch between HER2 0 and HER2 low, and vice versa. So in the old days or nowadays, when we are not using T-DXd, when we're talking about Herceptin, so it does not affect our treatment protocol. But when we are talking about treatment for HER2 low cancers, then it really affects our treatment protocol. So we need to sort this out. And also HER2 low expression may be enriched in advanced stage setting. Another very interesting paper was published earlier, again, a few years back. The authors look at compare core needle biopsies and whole section for HER2 expression. So if you look at this particular column, they have looked at 69 cases here that were core needle biopsy HER2 negative. However, when they look at the whole section, only 22 were whole section negative, 18 were whole section 1+, 25 were whole section 2+, and 4 were whole section 3+. So actually, you can see that out of these 69 cases, only less than 1/3 were concordant between the core needle biopsy and the whole section. So it's really alarming. So you can see if you only divide the things into positive or negative, like what we're doing now, then there's good correlation between core needle biopsy and whole section. For example, if you only look at this, like we divide it into positive and positive and negative, so the concordance is actually pretty good. However, if you base 4 tiers, if you want to divide the core needle results into 0, 1, 2, 3+, and compare with whole section 0, 1, 2, 3+, then the discordance is very low, and the concordance rate was only 38%. And most cases of discordance were found in IHC 0 and 0 to 1 categories. So maybe we need to repeat these stainings, or maybe on all the whole sections. Nobody knows what to do now. And these authors have observed that there are specific staining patterns for HER2 low stainings. So they observed that there are 2 patterns of HER2 staining in a scenario of HER2 low cancers. The staining can either be homogeneous or heterogeneous. When it is heterogeneous, it can either be clustered or mosaic. So I'm showing you these patterns. So this is homogeneous staining, but it's HER2 low. So you can see complete, most of the cells show very weak membrane staining. Clustered staining is heterogeneous, and you can see patchy staining. Some cells are totally negative and some cells are positive. There's a mosaic pattern, and every cell shows a little bit of staining in the membrane. All right, so it's also very interesting that all homogeneous staining pattern occurs in ER-positive cancers, and some of these, but these can occur, the clustered and mosaic patterns can occur in both ER-positive and ER-negative cancers. So we don't know the significance of this, but we need to know this so that we can correlate with our ER findings when we are assessing case with HER2 low. There are also significant inter-observer variability in HER2 low assessment, because traditionally we were taught to differentiate between HER2 positive and HER2 negative, and we don't care too much about HER2 0 and HER2 1+ in the old days. So the reproducibility of HER2 low among pathologists was suboptimal. So we can see in this study, the authors compared a pathologist's scoring over different sets, and they found almost perfect agreement for HER2 0 and HER2 3+. Substantial agreement between 1+ and 2+, and very bad concordance between HER2 0 and HER2 1+. So you can see HER2 0 and HER2 1+, when you do it And when I do it at the same time, we may not come up with the same diagnosis. So this becomes a great difficulty, and I think it would take a lot of efforts for us to align ourselves in the diagnosis of HER2 0 and HER2 1+. And again, I would like to show you using different antibodies may also alter your results. And there are two antibodies here in this study that the authors look at. This is a Herceptin antibody, and this is 4B5. So both antibodies are very commonly used. In A and B, you can see that 4B5 show cytoplasmic staining, which is, we know is negative, but it's cytoplasmic, whereas Herceptin antibody has no cytoplasmic staining. However, in this pair, you can see that the Herceptin antibody shows mild or weak normal epithelial staining, which should not be, but 4B5 did not show this. And then you can see that here in E and F, you can see 4B5 did not show as much staining as Herceptin antibody. So you can see there is fundamentally some difference between the two antibodies. So it depends on what antibodies you use, you get different results. This is the same paper. They compared the sensitivity, and in general, after digesting all this, I can tell you that it is found that 4B5 is less sensitive than the Herceptin antibody. So if you look at this particular 2x2 table, this is Herceptin monoclonal antibody, and this is 4B5 antibody. So you can see most of the stainings, they correlate, but for this group here, there are a significant number of cases that were Herceptin and monoclonal antibody positive, but 4B5 negative, and this is 4B5 1+, but monoclonal 2+, etc., etc. So 4B5 tends to show weaker staining than monoclonal antibody for Herceptin. So here's a comparison of the other two. So this is monoclonal antibody for Herceptin, and this is 4B5, and you can see for all these cases, they tend to show higher intensity staining using monoclonal Herceptin antibody than 4B5. Pre-analytical factor also zoom in into this. So ESCO guideline has suggested for evaluation, we have to immediately incubate incubation of tissue and fixative, minimizing cold ischemic time to less than 1 hour, fixative time 6 to 48 hours, and 10% neutral buffered formalin. So we know the fixation time does not affect HER2 0 and 3+ results, but it's not clear whether it has any effect on HER2 low categories. So to summarize, HER2 low category is a large category of heterogeneous breast cancers. Our interest in this is because of the effective treatment by the antibody drug conjugates. So currently, the testing for HER2 low is still a work in progress. There are a lot of confounding factors that would affect our accurate or reproducible assessment of HER2 low. Lack of reference standard, tissue heterogeneity, including temporal and spatial heterogeneity, high inter-observer variability for IHC 0 and 1+ cases, and the assay sensitivity and standardization, the antibodies, and the pre-analytical factors may also affect the results of the staining. So with this, I conclude my presentation, and I thank you all for your attention. I apologize for running over time a little bit, and please feel free to ask any questions. Thank you.
Thank you very much. Thank you. I have a couple of questions here for Dr. Gary. Someone asked, thank you for the nice presentation. Can you give some insight about the HER2 ultra low?
HER2 ultra low is, what is HER2 ultra low? The definition is, right now, I think we need to clarify from their audience. As far as I know, if you go back to this, so you can see the HER2 low is basically derived from the IHC staining and combined with our reflex test. So the HER2 low definition is IHC 1+ or IHC 2+, but they were non-amplified. So the IHC 1+ is more than 10% faint staining. So that's incomplete. So this is the so this would be the HER2 low definition. Unless you splitting up the HER2 negative into totally negative, or something between HER2 1+ and HER2 negative?
That's so difficult. As you mentioned, there will be a lot of inter-observer variability, you know.
Yes.
I have another question for you. In a core biopsy, if there is a high-grade spindle cell lesion or tumor with the focal positivity of cytokeratin, do you think it's safe to be called metaplastic carcinoma, or we should call it like malignant phylloides where the epithelium was not sampled?
That depends on the, to me, I would look at two things. Firstly, I assume there is no benign epithelial components, it's only pure spindle cell. So firstly, I would look at the way the E13 was stained. If it's patchy and weak, then I would be more careful. If it's very strong and very diffuse, then I would think then it would be more in favor of cancer than a phylloides tumor. Having said that, if you have problems, you can always say it is high-grade spindle cell lesion and give the differential diagnosis, because it's not fair in a biopsy to make a correct diagnosis, because in malignant phylloides tumor you would need to sample very extensively, sometimes to find the normal epithelial component.
Yeah, true.
I've made mistakes, and I thought it's, when I think it is a metaplastic carcinoma, and then after the tumor was excised, and in block 45 we find a small area of benign epithelium.
Yeah, I can't imagine. We will have a group photo, by the way. You are escaping. Sit down. Yeah, we have a question from our pathologist here. Yeah, Dr. Sleiman.
Okay. Yes.
Okay, thank you very much for the presentation. Basically, I have two questions. The first question is, I mean, as you did mention in your presentation, there is a difficulty between 0 and 1. And now, because we have to report 1 as not negative, isn't it? So would you think there will be sort of like a clear-cut criteria between 0 and 1? Any revision of those criteria?
I think the smart people in breast pathology circle would be looking at this, and they would come up with something that's more reproducible and sustainable. Remember when HER2 first came around 20 years ago, we were still reporting all left, right, and center. We don't know what we were doing. And now we are very good at reporting the 0 and positive. So I'm sure this we'll go through the same thing again. And this time it's between 0 and 1+. And I'm very optimistic that we will be able to sort this out. However, if you look at the two clinical trials involving T-DXd, the Destiny trial and the DAISY trial, you can see that even if the tumor is HER2 0, there is some response to T-DXd, partly because of the so-called bystander effect. When the tumors were killed, actually, tumors without HER2 can also be killed with this T-DXd. It is the same story as the PD-1, PD-L1. I think at some point the oncologist may decide to give T-DXd irrespective of the HER2 status, whether it's ultra low or almost 0 type of low.
Sure. And my second point is basically, are you still using the word negative when you call it 1, or you just put it like 1 and leave it? Because most of our labs here are CAB accredited, and we are following the CAB guidelines for the reporting.
So I think the CAB report is still 1 and 2 and 3, right?
Yes. Yeah. We put like 0 negative, 1 negative, 2 equivocal, and 3 positive.
Yes, I think we should do that. Otherwise, it's you're creating more confusion for our oncologist. If you say negative and positive, then they will know whether they're going to give Herceptin or not, and whether when it comes to T-DXd, then they will look at the number and not your positive and negative.
Okay, that's fine. The third thing, basically, would you think that the concept of HER2 low would be applied for the other HER2 test, for example, the gastric and the other ones, or?
I'm not aware of any trials on gastric HER2, but I'm not very up to date on these. Maybe you can enlighten me if you know of any clinical trials going on. I think the excitement on the HER2 low in breast cancer was mainly caused by the availability of this antibody drug conjugates. So I would not be surprised to find that it would spread to other cancers.
Okay, my last point basically is with post-neoadjuvant cases. I mean, as you know, sometimes we have like one and it's becoming three after. So I think the situation will be exactly the same here now, and we'll get more and more of those. Yeah. So do you think, you know, like repetition of HER2 will be sort of like in every specimen, or? I mean, if it is, for example, in the core biopsy was reported as 1 or even 0, because there is always a possibility of change. And
yes, there's always the possibility of change. But think about this: if you are offering neoadjuvant chemotherapy to your patient, then you will still need to perform accurately the HER2 test on the core biopsy. And after the neoadjuvant chemotherapy and with the tumor excised, then you would need to perform that again, like as per CAP guideline, and most people would do that, so that the post-op adjuvant therapy can be given in an optimal manner. So I think it is the same practice. It's not going to change our practice, but our practice is also very good because we repeat our tests after any treatment after the treatment.
thank you very much.
Thank you.
Thank you, Dr. Gary, for this really interesting topic, especially the HER2 low. I have a lot of messages, many thank you messages for the interesting talk. Do we have any more questions? 2 questions, maybe the last 2. There is one point not clear for me. When I recommend to wait for excisional biopsy to repeat HER2 IHC.
Oh yes, yes, I'm seeing this as well. When I recommend to wait for excisional biopsies to repeat. I'm not exactly sure, but basically what happens is in the 2018 guidelines, if you look back, let me see. If you look back at the 2013 guideline, these are the conditions in which the guideline says that you have to repeat. But now the guideline is changed to you can consider repeating. But I think these are very valid scenarios in which there's a chance that the core needle biopsy may not be correct. So if I see this, I would repeat.
Thank you very much. Thank you. I guess it's late now in Hong Kong, isn't it?
No, it's not.
What time now? Totally
it's 10:30.
Oh, okay. All right. Thank you very much, Dr. Gary, for the people here and for the people online. You can see the recorded lecture in our website at SSMC Abu Dhabi Surgical Pathology. I would like to thank you once again. It was really nice to see you and to listen to you. Thank you very much and have a great
Yes, thank you very much.
Thank you.
Okay, thanks. Bye-bye.
Bye-bye. Would you have a group photo, please? Thank you.